relevant topic discussion, which is on fertility preservation and what every gynecologist should know. Dr. Vyjayanthi S would be taking us through this subject. Welcome, ma'am.
Good afternoon, everyone. At the outset, I would like to thank Dr. Jayakrishnan sir for giving me this wonderful opportunity to be here today. Fertility preservation is a subject very close to my heart since my fellowship days back in the UK. While I was doing my subspecialty fellowship at St. Bart's in London, both the oncology unit and the fertility unit were housed in the same building, and every so often we used to see young women who had just had surgery for breast cancer, either lumpectomy or mastectomy, walk into the unit with drains in situ for fertility preservation. And this was the oncology services were very streamlined, and from one to another they could go on to have the fertility preservation. So in my talk today, I'll be focusing on why, when, how, and what of fertility preservation in the setting of oncology, because this is an oncology session. And towards the later part of my talk, I'll also very briefly mention regarding the non-oncology conditions where we would consider fertility preservation. So in my talk today, as I said, after this streamline onco-fertility services, what are the fertility preservation methods, efficacy, and the safety profile? I'll also share with you a couple of case scenarios which we have managed, and also the challenges we face when we offer fertility preservation. The most important need of the hour is to create awareness regarding fertility preservation, and with this in mind, the FPSI, or the Fertility Preservation Society of India, was formed almost 10 years ago, and it's doing yeoman service. Cancer survival rates are increasing, and these days up to 1% of young women are cancer survivors. As you can see from this population-based study, because of the high cancer survival rates, about 20 to 80% of the women suffer from reduction of fertility, and there is also increased risk of premature ovarian failure. So advances in cancer diagnosis and treatment means the odds of survival has increased. So many of these women have achieved cure from cancer. So when this chapter in their life is over and they look forward towards the next chapter in life, if fertility preservation has not been taken care of, they suffer from subfertility, and this severely affects their quality of life. And that is the very reason every young men and women who need fertility preservation should be seen by a reproductive medicine specialist prior to starting oncology treatment. So when we talk about the gonadotoxicity of the chemotherapeutic agents, it can either be high risk, medium risk, or low risk towards the gonads. But what happens is some of these chemotherapeutic agents affect the primordial follicle. They cause DNA damage, leading to oocyte apoptosis, which means that even if the cycles return to normal post-chemotherapy, these women will suffer from a shortened reproductive lifespan and achieve premature menopause. And some of these agents affect just the dividing cells. So there are three important aspects when we want to find out about the effect of chemotherapy on the fertility and the ovarian reserve. One is what chemotherapeutic agent is being given. The second is the age at which this chemotherapeutic agent is given. So if you seek from the chart, the optimum fertility is between 20 to 30 years of age. So when they cross 30, what happens is the ovarian follicle pool declines. So if at this stage a chemotherapeutic agent is given, the effect is going to be more intense. And their primary ovarian reserve. So what we mean by oncofertility is to get a collaboration between reproductive medicine specialists and the oncologists. So fertility preservation, when we see even in centers of excellence, is offered ad hoc. So introducing oncofertility services will help create the bridge between cancer care and reproductive health. So when we talk about creating onco-fertility services, we want to bridge the information gap and the knowledge gap that exists between fertility specialists and the oncologists. So this also helps to develop strategies and algorithms to streamline fertility preservation. So when we talk about an onco-fertility team, from oncologists to one side, fertility specialists are on the other side. Counselors and coordinators also form a very important part of the team, and they form actually the backbone of the team. So counselors are here to provide emotional support and support these young men and women during a very vulnerable stage in their life, because they have quite a lot to take on board. It is not just the cancer treatment they have to process, they also have to process fertility preservation procedures. So this is very important that both oncologists and fertility specialists work together to ensure that every young man and women in need of fertility preservation do get offered these fertility preservation procedures prior to starting the oncology treatment. So now moving on to what are the fertility preservation techniques available, how effective are they, and is it safe in hormone sensitive cancers like breast cancer and endometrial cancer, and will it affect long-term prognosis if fertility preservation is undertaken. So now coming to the procedures, the very common procedures which we do for fertility preservation, which can be done in fact in any standard IVF unit, is embryo cryopreservation, oocyte and semen cryopreservation. Actually, in a significant majority of young men and women who need fertility preservation, these techniques would suffice. So as I have mentioned, any standard IVF unit can offer these fertility preservation techniques. But when we move on to in vitro maturation, this needs expertise, and we offer this particularly when time is an essence. Particularly in hematological cancers, we don't have much time to do the 10 days of stimulation which we need when we do embryo preservation or gamete cryopreservation. And ovarian transposition is done when pelvic radiation is needed. And when we talk about ovarian tissue cryopreservation, this is mainly for prepubertal girls. And we should also consider fertility sparing surgeries wherever the reproductive thing has to be maintained in women. So now when we talk about these different procedures, what procedure we are going to choose is based on the patient's age at the time of diagnosis, the type of therapy which is going to be given, and the time available prior to chemo or radiotherapy. So as I have mentioned, these are standard procedures which can be offered in any standard IVF unit. When we talk about IVF, IVM, as I have mentioned, this needs special expertise, and the same applies to ovarian tissue cryopreservation and testicular tissue cryopreservation. But when we talk about IVM, still the success rates with IVM is not as good as a traditional straightforward IVF which we do. The success rates are still far low, but when time is the essence and we can't do the traditional IVF, that is when we want to do IVM. And when we talk about ovarian tissue cryopreservation, several births have occurred worldwide using the ovarian tissue which has been cryopreserved, which has been reimplanted, and so it is no longer an experimental protocol. But when we talk about the testicular tissue cryopreservation, it is still in the nascent stages. And the tissues have been cryopreserved, but we still have not got even a single pregnancy. And hopefully in the next decade to come, we will be hearing more regarding the testicular tissue success rates. Now moving on to how effective is fertility preservation. When we talk about embryo cryopreservation, with the advent of vitrification, which is the rapid freezing, this has revolutionized the success of embryo cryopreservation. So these days we have a post-thaw survival rate of more than 95%, which means it is highly effective. So when we move on to oocyte cryopreservation, as we can see, initially it was considered as an experimental thing, but now in 2013 that label was removed. And in 2016, as the systematic analysis shows, using the vitrification technique, the IVF pregnancy rates using these vitrified oocytes is almost similar to the fresh oocytes. And when we talk about sperm semen cryopreservation, the process is more straightforward, and there is really no excuse not to offer semen cryopreservation because there is no cost involved here. I mean, the cost involved is very minimal and the process is very straightforward. What we need is just few samples. And even when the patients are very sick, which we see with hematological cancers, we still, even if few sperms are there, we will be able to use those sperms, and later on he can have his own genetic child. So it is very important to consider this. As I said, when we talk about embryo cryopreservation and oocyte cryopreservation, cost is a major impediment, but that doesn't apply to semen cryopreservation. So for coming to the, to summarize about the effectiveness, it is highly effective, and when we talk about fertility preservation, the IVF units which offer them should provide high standard of care, and quality control measures should be in place. So timeline of fertility preservation, what is the timeline we are looking at? And the second common question which is asked is, if I am going to delay my starting, say for instance chemotherapy for 10 days to do this stimulation, will it affect my long-term prognosis? There is now a large body of evidence to state that delaying the fertility chemotherapy because of fertility preservation by 10 to 12 days does not affect the long-term survival rate. So when we talk about the duration, for instance, breast cancer cancer yields easily to fertility preservation. Say they have surgery for either lumpectomy or mastectomy, and then if they need chemo, we have this 2 weeks, 3 weeks interval between surgery and chemo, and this is where, as fertility specialists, we get in and do the ovarian stimulation. Previously, we used to think there's only one follicular wave occurring at the early part of the menstrual cycle, and we have to start the ovarian stimulation at the beginning of the menstrual cycle. But now we do what is called random start, which means if the patient is referred to us today we can start the protocol, because we know that now there are multiple waves of follicular activity happening all through the cycle. And if time is available, we can do duo stimulation, which means first 10 days block of stimulation we have done, we have collected the oocytes, we can straight start the second block of stimulation. And as I have mentioned, even if there is a delay in chemo, to start chemo by 2 weeks, it does not affect the overall outcome. So when we talk about the number of oocytes in an elective cryopreservation setting, we talk about the numbers, but in the context of oncology, any oocytes we get, it's fine. So that is the concept which we go in. Now coming to the question, is IVF process safe? Because these women are already fragile from the diagnosis of cancer, and will their health permit if OHSS happens? But these days, with the advent of antagonist protocol and GnRH agonist for trigger, we don't see OHSS these days, and I can say that OHSS has literally been removed from the dictionary of the IVF specialist in the context of IVF. And in my own practice, I can say hand on heart, my last case of OHSS was 10 years ago. And is fertility preservation safe, as breast cancer is hormone sensitive? So whenever we have hormone sensitive cancers, we add letrozole to the stimulation protocol. So if you see here, in an IVF cycle, we are looking at around 1000 to 2500 picogram per ml as the estrogen level. But when we look at a natural cycle, it's about 300 to 600. But when we do IVF with letrozole support, you can bring down these estrogen levels to less than 1000, which is almost similar to what you see in a natural cycle. So there is no challenge of it being unsafe. So now, moving on to ovarian tissue cryopreservation, we call it as the Edinburgh criteria to be fulfilled when we consider ovarian tissue cryopreservation. This is, age should be less than 35 years, but as I mentioned, mostly we are looking at prepubertal girls, and should be a 50% risk of chemotherapy-induced ovarian failure, and there should be realistic survival rates. The advantages: there is no delay in starting definitive treatment when you do ovarian tissue cryopreservation. You're going to do a laparoscopy this morning, remove the ovarian tissue, and next day they can start their chemotherapy. And the advantage with that is that it resumes endocrine function also when we replace this ovarian tissue at a later date. The disadvantages is that it requires a surgical procedure. So we offer OTC as of now to prepubertal girls, though it can also be offered to adults. So coming to a couple of case scenarios, I'll take you through. This is a lady at 36 years, 7.5 years of subfertility, presented to us for IVF treatment. During the process of IVF, we noticed that the endometrial thickening was too thick, and so we froze the embryos and did a hysteroscopy for her. It showed thickened polypoidal endometrium, and the histology showed endometrial intraepithelial neoplasia with a focus of invasion. So she was treated with high-dose progesterones, and we do repeat the biopsy every 3 months. And once 2 biopsies come back as negative, then we are in a position to replace the embryo back. So this lady had the high-dose progesterone. We usually use megestrol acetate 80 milligram twice daily, and she then went on to have the frozen embryos replaced and delivered a term baby. So this is another lady, again very young, 31-year-old, has PCOS, presenting with irregular heavy periods. So a pipple biopsy done did pick up endometrial CA at a very early stage, but here if you see, her MRI also showed less than 3 mm invasion. So she was actually initially referred to a surgical oncologist and was suggested total abdominal hysterectomy with unilateral salpingo-oophorectomy, but she came to us for second opinion and we could offer her conservative treatment. So the treatment is, we resected the endometrium, put the Mirena coil and added megestrol acetate. So we have done biopsies now. Recently her 2 biopsies have come back as negative, and now we'll be getting on to do the IVF treatment for her. 7% of endometrial cancers occur at a very young age, and we have to be very careful with PCOS women because endometrial CA in these women can occur at a very early age, even in early 30s. As I showed here, our patient was only 31. So basically, endometrial CA conservative treatment is resection of the endometrium, Mirena coil, high dose progesterones, and once the biopsies become negative, we don't have much time here. We have to get in, do the IVF treatment, get them pregnant. So soon after their delivery, then they can go on to their definitive treatment. So coming to breast cancer, these days we are seeing breast cancer also at a very, very young age. The youngest lady with breast cancer we had was 22 years old, unmarried, for whom we did oocyte cryopreservation. And lifestyle changes, and we are going to see more and more cases of breast cancer with the way we are heading. So now when we talk about breast cancer, and just for lack of time, I'll really be quick here. So here again, as we said, between surgery and chemo, we are going to preserve either the eggs or the embryos based on whether they are married or unmarried. And when these women are ER/PR positive, post-surgery and chemo, they also have to go through 5 years of either tamoxifen or letrozole or anastrozole therapy. So when we talk about fertility preservation in breast cancer setting, if you are going to have surgery followed by chemo, you can get in the window period, do fertility preservation. If they are going to have neoadjuvant chemo, which is the primary chemo followed by surgery at a later date, we can still do preservation of oocytes or embryos. And once this too is over and they are going to go on tamoxifen, say for instance the lady's age is 32 and they are going to go on tamoxifen for 5 years, this will take them through 37 or 30 years, or 80 years of age, when they will really find it difficult to conceive. So there's recently a trial called Positive trial which has been published. Here the study showed that after 18 months of tamoxifen treatment or letrozole treatment, we can stop the hormone treatment and have a window period of 1 to 2 years when they can conceive, and then they can go back on their hormone treatment. By doing this, they're able to complete their family and also complete the treatment for cancer. So this is something which we should be advising them when it comes to breast cancer. Different stages we are able to help them. Now, the other cancers for whom we have personally done fertility preservation are Ewing sarcoma. This girl was only 18 years old and she had to go for chemo, so we could preserve her oocytes. Gastric adenocarcinoma, Hodgkin's lymphoma also is very common, and rhabdomyosis. These are all the other cancers which we have been offering over the past decade. We have been offering, and these are some of the cancers we have offered fertility preservation. So what are the challenges we see when we offer fertility preservation? Two most important. One is acceptance, second is cost factor. So when we talk about acceptance, if the primary physician, who is usually the oncologist who looks after the patient, initiates the fertility preservation discussion and also reassures them that undergoing fertility preservation is not going to affect their long-term survival, then these women are more accepting of FP when they reach out to us at the second phase. So, and again, another most important thing is institution characteristics. We see that some institutions are able to do this FP in a better way compared to other institutions. So the support is very, very essential. In our own unit, personally, 1 in 3 who are referred to us for fertility preservation agree to proceed. The major challenge we see is the cost factor. So, and again, when I talk about acceptance, young women with breast cancer also find it quite overwhelming. They already have a diagnosis of cancer. They need to process all the treatments which has been suggested to them. They are quite overwhelmed with this. On top of this, if you are going to say that they also need fertility preservation, you need this, they find it really overwhelming. And this is where support from counselors and also family plays an important role. And this is a publication which showed that though women found it quite overwhelming at the time to talk about fertility preservation, in addition to the cancer treatment, later on when they had to when they reflected back, they thought that it was the right thing to do for them, though they found it overwhelming at that point. So as I mentioned, in our country, cost is the major factor, and it is self-funded in India, whereas in countries like UK and Europe, it is state-funded, and it is quite streamlined. But in India, that is the major impediment we see when we talk about fertility preservation. Even if they don't agree on fertility preservation, we have to support them, and as I said, they have a shortened reproductive lifespan, so soon after chemo, they have to be seen, fertility assessment done, and they have to be supported. So So algorithms like this are very important to streamline the onco-fertility services. So just a brief mention about the non-oncology conditions. Though fertility preservation started with oncology cases, now it is widening the indications. And for instance, in the gynecology side, it's mostly endometriosis we are looking at, and medical disorders like rheumatological diseases also we offer FP, and hematological conditions like thalassemia. These young women need bone marrow transplant. Prior to that, we offer fertility preservation. And for social reasons, which is age-related fertility decline, fertility preservation or oocyte preservation is done in a very commonly these days. And we are also now able to offer it for transgender men and women. So this is the long list of non-oncology conditions where we can offer fertility preservation. So when we are going to offer it for social reasons, it is ideal in the 20s. And celebrities like Diana Hayden has popularized the social egg freezing. And when we are going to do it for the social freezing, ideal, as I said, in the 20s. And these days, some companies are also offering for funding to do these oocyte preservations. And when we talk about endometriosis, we talk about only one surgery in a lifetime these days. So whenever a young girl in their late teenage or early 20s presents with big endometriotic cysts, after removing the cysts, we have to put them on preventive treatment, and also they have to be offered fertility preservation. Can I take another 1 minute? Thank you. Why do we need to consider fertility preservation in rheumatic diseases? This is mainly because the autoimmune disease, which leads to the rheumatic diseases, also leads to poor ovarian reserve. And secondly, the severity of the rheumatic disease means these women have to delay conception, and age-related fertility decline sets in. And in some other women, they have to take cyclophosphamide, which also can affect fertility. So these days, we have been offering fertility preservation for women with rheumatic diseases, and ART can be done in women with rheumatic diseases quite safely. So to summarize, fertility preservation in young men and women with cancer is a need of the hour, is to create awareness, and onco-fertility services with defined care pathways have to be established, and the currently available methods of fertility preservation are highly effective, but the challenges are the acceptance and the financial burden. And as healthcare professionals, we should all be able to work together to provide any young men and women, all young men and women who need fertility preservation. We should be able to support them. Thank you.
Thank you, Doctor, for this insightful session.